Clinical examination of the musculoskeletal system. In the examination of the knee joint, we are looking for inflammatory, mechanical, or traumatic pathology. So expose both knees for adequate visualization and comparison, and observe the knee for swelling, discoloration, erythema, cyanosis, or bruise. So look for wasting of the quadriceps muscles and compare with the opposite side. And look for evidence of flexion deformity and genu valgus, that's knock knee, or genu varus, that's ball knee or ball leg. Sometimes angulation of the knee is the same on both sides and is called windswept knee. Thomas test is used in fixed flexion deformities. It is done by flexion of both knees straight up to the chest. Then hold the other knee to the chest and try to bring down the back. That is the popliteal fossa of the affected knee onto the couch. In fixed flexion deformity, the patient is unable to let the knee be flat on the couch. So measure the angle of fixed flexion deformity using a goniometer, and observe cutaneous lesions in sole of feet such as keratoderma blenorrhagica, and observe the nails and skin for evidence of psoriasis. Also observe the forefoot for deformities such as broadening in rheumatoid arthritis, and all these will give valuable information as to the possible cause of the pathology in the affected knee. Palpate for the nature of any swelling present, for example, fluctuancy in effusion, synovial thickening, osteophyte bone enlargement, and then palpate the joint itself to detect any active inflammation. Compare the temperature of the joint. I'm using the middle of the lateral thigh as reference point, and palpate the soft tissues for any tenderness. The presence of warmth and tenderness indicates active synovitis. And perform the patellar tap sign to determine moderate effusion. In osteoarthritis, if osteoarthritis is present, the patellar tap sign is negative in the presence of small effusion, and small effusions are detected by trapping fluid in suprapatellar pouch and gently stroking the fluid into inframedial compartment of the knee. A small waveform is seen. Synovial thickening is palpated by firm pressure of fingers and thumb upwards in the infrapatellar region and feeling for the femoral bridge structure. So feel for any bony thickening and assess the distance between the two condyles. Palpate over superior and anterior aspect of knee for evidence of peripatellar bursitis. Apply firm pressure on the medial and lateral aspects of knee for tenderness. Pain in the young patients may indicate chondromalacia patella. Palpate for cystic swelling behind the knee in Baker's cystic condition. And in rheumatoid disease, this may extend down into the calf, and this can then rupture, causing pain and tenderness, which mimics a deep vein thrombosis. And if there is no swelling in a painful knee, the pathology may be in the soft tissue or capsule. Firm pressure in the superior and inferior aspects of the patella may lead to tenderness due to tensopathy, which is a disorder of the muscular and tendinous attachment to the bone. The point of insertion of ligaments in tibia may also be tender. And another cause of tenderness is infrapatellar bursitis. The collateral ligaments are also a potential source of pain and testopathy. The test for range of movements: get the patient to actively bend the knee to assess the comfortable range of movements for the patient, and place a hand on the knee as he bends the knee for crepitus. And if crepitus is detected, it indicates osteoarthritis, or in a young adult it may indicate chondromalacia patella. Any limitation of movement is measured with goniometer and accurately recorded. To test for the ligaments, you raise your elbows on the inner legs and firmly grip the upper end of the tibia. Lean forward and try to induce anterior and posterior movements of the tibia and the femur, and this felt as well as seen. To test for instability of the collateral ligaments, you slightly flex the knee and grip the lower end of the tibia and move it laterally. To assess mobility at the knee, attempt valgus and varus movements of tibia and assess the stability of the knee joint. Rotate the tibia on the femoral condyle by firmly gripping the calcaneum with the right hand and also applying tension. So this produces pain on the medial and lateral compartments. Now you get the patient to lie down in the prone position. You try and rotate the tibia and the femur, and to test for disease of the meniscus, you exert pressure downwards on the tibia to compress for the meniscus. The pain in meniscus will increase if there is pathology in the meniscus. Instructions, that is lifting the heel away from the knee, reduces the pain in the meniscus. If no pathology of the knee is detected after careful examination, then the cause may be a pathology of the hip on the same side, giving referred pain to the knee. It may also be referred pain from the lumbar spine at L3 and L4, and in this case you need a neurological examination to detect nerve root compression. Now let's look at the function. So lastly, you get the patient to stand and bear his weight. Get him to walk and observe the gait, and also observe the knee for varus and valgus deformity, which is more obvious when he is walking, and also observe for stiff knee joints